Hello everybody and greetings from MedTube channel for another series of videos on electrolyte abnormalities and acid-base disturbances. Starting off today with the most common electrolyte abnormality encountered in clinical practice, which is hyponatremia. And as usual, starting with the definition of hyponatremia, it is defined as a serum sodium concentration below 135 milliequivalents per liter. It could be hypoosmolar, isoosmolar, or hyperosmolar, as we will be seeing shortly. Hyponatremia usually presents with neurological symptoms secondary to cerebral edema, and that's because the water is driven from the extracellular compartment to the intracellular space through osmosis, causing the brain cells to swell. Now, hyponatremia could be classified both etiologically and clinically into the following. We have the first category, which is hyperosmolar hyponatremia. We have isoosmolar hyponatremia, and finally we have the hypoosmolar hyponatremia, which is actually the most common category and the most significant one. So let's first start with the hyper and the isoosmolar categories, and then we'll finish with the hypoosmolar. So starting with the hyperosmolar hyponatremia, and as the name suggests, your plasma osmolality is high, usually above 295 milliosmoles per kilogram. But if I ask you the following, how could you have a high plasma osmolality and at the same time you have low sodium? And the answer is you have other osmoles contributing to the plasma osmolality. In other words, you have osmotically active substances that are drawing water into the blood, causing the hyponatremia, which could be due to any of the following, with the most common, of course, being the severe hyperglycemia, as seen in DKA or hyperosmolar hyperglycemic state. Other causes would be hypertonic mannitol, maltose or sucrose solutions, which are used to deliver the IV immunoglobulin, or an advanced renal failure. Now, what really happens in advanced renal failure is the retention of free water, which causes dilution of the sodium and therefore hyponatremia. But since you also have retention of urea, which is an osmol, your calculated serum osmolality will be high. But since urea is an ineffective osmol, your effective serum osmolality will be low. And therefore, advanced renal failure actually fits better under hypoosmolar hyponatremia because it's the free water that is causing hyponatremia and not the urea. And finally, please note that in hyperglycemia, you could actually have a high sodium concentration in some patients, and that's because of the osmotic diuresis associated with hyperglycemia, and therefore the loss of free water causes the sodium concentration to increase and to further increase the plasma osmolality. And now coming to the second category, which is isoosmolar hyponatremia, and as the name suggests, it is caused by isotonic solutions as in glycine, sorbitol, or mannitol non-conductive irrigation solutions, which are used in TURP procedures, which is transurethral resection of the prostate, or in hysteroscopy procedures. Now, these solutions are called non-conductive because they do not contain electrolytes, and therefore they do not conduct electricity, and therefore they are safe in unipolar electrocautery, which was commonly used in the past. But nowadays, since we use the bipolar electrocautery, we do not need these non-conductive solutions anymore. We could use the conductive solutions which contain electrolytes, as in isotonic normal saline. And isotonic normal saline does not have the risk of hyponatremia anymore, as in those solutions. But if I ask you the following question, why in isotonic normal saline you do not have a risk of hyponatremia, whereas in those isotonic solutions you do have a risk of hyponatremia? And simply the answer is that isotonic normal saline contains sodium. So logically, even if it's absorbed in large amounts during these procedures, they do not cause hyponatremia. But if they are absorbed in large amounts, they could cause other problems, as in fluid overload and pulmonary edema. Another cause of isoosmolar hyponatremia is pseudo-hyponatremia, which is not a true hyponatremia, but it's rather a lab artifact, and it's seen in severe hyperlipidemia or paraproteinemia. What happens is that normally the water fraction of plasma is 93%, with the fats and the proteins accounting for the remaining 7%. But in hyperproteinemia or hyperlipidemia, you have a plasma water fraction of less than 80%, and therefore you have a measured sodium concentration that would be low for the specimen that you have measured because of the low plasma water fraction. But your sodium concentration in relation to the plasma water fraction only will be normal, and your plasma osmolality will remain normal. And now coming to the last and the most important category, which is hypoosmolar hyponatremia. And what we have here is a dilutional hyponatremia, which is excess water in relation to the sodium without the action of any effective osmoles, as seen in the previous ones. But here we simply have excess water, and therefore we have a hypoosmolar hyponatremia. Now, hypoosmolar hyponatremia is usually classified according to the volume status of the patient, but it could be also classified according to the ADH levels. But in here, we're following the volume status. And we have first hypervolemic hypoosmolar hyponatremia. We have euvolemic hypoosmolar hyponatremia. And finally, we have hypovolemic hypoosmolar hyponatremia. Now, what happens in hypervolemic hyponatremia is that you have an increase in both the total body sodium and the total body water, but the increase in total body water is more in relation to the increase in total body sodium, and therefore you have a dilutional hyponatremia. What happens in euvolemic is that your total body sodium is actually normal, but you have an increase in the total body water, and therefore a dilutional hyponatremia. And finally, we have the hypovolemic hyponatremia, which could sound paradoxical. How could you have a hypovolemic patient with a hyponatremia? And the answer is you have a decrease in both total body water and the total body sodium, but the decrease in the total body sodium is more than the decrease in the total body water, and therefore in the end result you will be having a dilutional hyponatremia. So let's start with the hypervolemic hyponatremia, and we have the following causes. First is the congestive heart failure and cirrhosis. Now in CHF and cirrhosis, the plasma volume and the extracellular volume are actually increased, but since the pressure which is sensed in the baroreceptors in the carotid sinus and the aortic arch is actually decreased because of the decreased cardiac output in CHF and the arterial vasodilation in cirrhosis, you will have an increase in ADH release and therefore more free water reabsorption and resulting in dilutional hyponatremia. And now coming to pregnancy, and what happens in pregnancy is that you have an increase in the beta HCG, and the beta HCG resets the osmostat downwards, and therefore you have a physiological increase in the release of ADH and an increase in the thirst response, and therefore you have a dilutional hyponatremia, which is normal in a pregnant woman. And now coming to the last cause, which is advanced renal failure, which we have already discussed previously, if you remember, in the hyperosmolar hyponatremia, and we have also discussed previously why we have included it in the hypervolemic hypoosmolar hyponatremia. And please note that an advanced renal failure could actually be euvolemic as well, so it could also be included in this category right here. And finally, please note that I have not included the nephrotic syndrome because a nephrotic syndrome usually maintains a normal effective blood volume and therefore does not trigger the ADH release unless there is a simultaneous renal failure associated with a nephrotic syndrome. And now coming to the euvolemic causes of hypoosmolar hyponatremia. And we can further classify them into two categories. The first is that you have a urine osmolality of more than 100, and we have several causes. The first is SIADH, syndrome of inappropriate ADH, and as the name suggests, you have an increase in the ADH release. Now, the golden question and a very common question that arises is why in SIADH specifically you will be having euvolemia. You will not have edema, you will not have hypervolemia, generally speaking, of course. And the answer is in SIADH, your sodium excretion is normal. And therefore, when you have an increase in the blood volume because of the ADH, you will have a release of the natriuretic peptides as the ANP, for example, the atrial natriuretic peptide. And this will result in the excretion of water and sodium in the urine, despite the high ADH. And on the long term, your sodium excretion actually will be more prominent than the water retention itself. And therefore you will have kind of a balance in the total body water, and therefore you will have euvolemia, and at the same time you will have hyponatremia because of both the fluid retention and the increased sodium excretion. And then we have adrenal insufficiency, and it has actually several mechanisms by which it causes hyponatremia, but making long story short, your decrease in the aldosterone level and the cortisol level will eventually cause an increase in the ADH and therefore euvolemic hyponatremia. And it's usually the secondary type that causes the euvolemic hyponatremia, not the primary adrenal insufficiency. And finally, we have hypothyroidism, and the exact mechanism is incompletely understood by which it causes hyponatremia, but several mechanisms have been proposed, as the inability to excrete free water, or the increase in ADH, or a third cause, which is that the GFR itself is reduced. And now coming to the second category, which is having a urine osmolality of less than 100, and we have several causes, starting with the psychogenic polydipsia, also known as primary polydipsia. And what you have here is an osmotic threshold for thirst that is lower than the osmotic threshold for ADH, and therefore you have a stimulation of thirst before you really have a stimulation of ADH release, and therefore these patients will not really have a hyponatremia usually, because whatever they drink because of the excessive thirst will be excreted through the urine because of the absence of ADH release. However, there are two mechanisms by which you could have a hyponatremia in psychogenic polydipsia. And the first one is that you drink a really huge amount of water all at once, such as 3 to 4 liters at once. Or the second mechanism is that you have somehow an increase in the ADH, such as a transient increase in ADH release due to the acute psychotic episode, or due to nausea, or due to stress, or due to a concurrent diuretic use in those psychotic patients. Or finally, it could be due to the increase in net response of the kidneys to the ADH. So even though you could have a normal ADH levels, but you have an increase of the kidney response to the ADH. So the end result of this increase in the ADH response, whether due to increased ADH levels or the increase in ADH sensitivity in the kidneys, you will have water reabsorption, therefore triggering the hyponatremia in those psychogenic patients. And now coming to the beer bottomania and the tea and toast diet, both of which have a low dietary solute intake. So it's not really the low solute, which are the electrolytes taken in your diet, that cause the hyponatremia. So it's not because you're taking low sodium so you're having hyponatremia. No, it's actually rather because your low plasma solutes will impair your nephrons' ability to excrete free water, and therefore you'll have free water retention triggering a dilutional hyponatremia. And now coming to the third and the last category of hypoosmolar hyponatremia, which is hypovolemic hyponatremia. And again, you have both water loss and sodium loss, but the sodium loss is more than the water loss. And we have two main categories, either renal causes or extra-renal causes, with the renal causes being the diuretics. And the diuretics are the most common cause of hypovolemic hyponatremia. and we have the salt wasting nephropathy, and you have urinary sodium, of course, of more than 20, and that indicates that your sodium loss is through the kidneys. So starting with diuretics, the thiazides are actually more likely to cause hyponatremia than the loops, and here is the reason. So as we all already know, the thiazides inhibit the sodium chloride cotransporter and the DCT, the distal convoluted tubules, and therefore they will draw the water into the tubules. And when this urine reaches the collecting ducts, in the presence of the ADH, this free water will actually be reabsorbed, leaving the solutes in the urine, and therefore you will have sodium excretion. But what happens in loops is that the loop diuretics inhibit the sodium potassium 2 chloride cotransporter in the thick ascending loop of Henle, right here, the thick ascending loop. And this thick ascending loop is actually the part of the nephron which is responsible for creating the osmotic gradient. And since you have inhibited the transporter in here, you will lose the medullary osmotic gradient in the nephron. And when the urine reaches the collecting ducts, there will be no more gradient between the tubule and the interstitium. So even though you have ADH, which is normal and functioning, there will be no free water reabsorption because the gradient is now absent. And therefore, the loops will be better diuretics, will lose the free water better, whereas the thiazides are better natriuretics, will lose the sodium better. And now going back to our list of the hypovolemic hyponatremia, and the next condition is called salt wasting nephropathy, also known as cerebral salt wasting syndrome. And what happens in this condition is that your proximal tubules are dysfunctional, causing a urinary sodium loss. And this sodium loss will increase your ADH release and therefore causing reabsorption of free water from the collecting ducts. And this will further aggravate your hyponatremia. And this condition is usually due to a central nervous system disorder, as in brain tumor or brain trauma or brain stroke or a brain hemorrhage, etc. Or it could happen in the absence of any CNS disease. Now the exact mechanism of how the CNS disease is related to your kidneys is incompletely understood, but there have been several mechanisms suggested, such as the increase in sympathetic activity and dopamine released caused by the injured brain, and this causes an increase in the sodium excretion by the kidneys. Or it could be due to an increase in the natriuretic peptides release triggered by the injury to the brain, and this also causes an increase in the sodium excretion. And now coming to the extrarenal causes, where you have a urinary sodium excretion of less than 10. And the same story is repeated over and over again. First, you have water loss and sodium loss through vomiting or diarrhea or sweating or third spacing, and you will have an initial hyponatremia. And this hyponatremia will be further aggravated by the release of ADH triggered by the water loss, and this will further cause a dilutional hyponatremia, and this dilutional hyponatremia could actually be further aggravated by the oral intake of free water. This is all for the classification and etiology of hyponatremia, and please note that these are not all the causes of hyponatremia, but there are few other causes which are not mentioned in this video. And now going to the management of hyponatremia. And of course, as always, the management starts when you see the patient. And when you see the patient, we start, of course, with the history taking. And with the history taking, the first thing to ask about is any causes of volume depletion, as any history of diarrhea or vomiting or diuretics use. Any history of volume overload, as in seen psychogenic polydipsia, increased water intake, or any known CHF, or liver cirrhosis, or advanced renal failure, all of which are usually associated with volume overload. We also could ask for any known endocrine diseases, as hypothyroidism, or diabetes mellitus, hyperglycemia, or any SIADH, or any adrenal insufficiency. We could also ask any history of trauma, as seen in head trauma, for example, and causing cerebral salt wasting. We could also ask about the diet of the patient, looking for beer potomania and tea and toast diet. And then we go to the physical examination and we start looking for any dehydration signs, as seen in decreased skin turgor, or decreased JVP,
or hypotension, or even decreased urine output. And then we look for any signs of hypervolemia, as seen in peripheral edema or in ascites. And then we look for clinical manifestations of any endocrinological diseases, as in diabetes or hypothyroidism. And then we assess the patient for any malnutrition, indicating any beer potomania or tea and toast diet. And then we go to the investigations, and we have lots of investigations, but of course the most important three investigations are the serum osmolality, the urine osmolality, and the urinary sodium, potassium, and chloride. And that's because when you know these numbers, you'll be able to classify your hyponatremia into one of the previous categories. And then finally coming to the treatment. And the treatment itself is actually very wide topic, which could actually require an additional video, but I'm just gonna mention a very small summary of the treatment. And of course the most important is water restriction to less than 1 liter per day, and that's to counteract the hyponatremia. But of course you have exceptions, with the first one being if the patient is hypovolemic, you will have to give the patient a normal saline. And if the patient has certain conditions, you will have to give a hypertonic saline, as in hyperacute hyponatremia, which is hyponatremia arising in several hours. And if you have acute hyponatremia, which is hyponatremia arising in less than 24 hours, or if you have any severe hyponatremia, which is defined as any hyponatremia with a serum sodium of less than 120, and if you have any moderate hyponatremia but it is symptomatic. So a moderate hyponatremia is defined as a serum sodium between 121 to 129, and if the patient is symptomatic, you would give hypertonic saline. Pretty much all the other conditions, that is if you have a chronic hyponatremia or a moderate hyponatremia and that is asymptomatic, you would only do water restriction. After stabilizing the patient, of course, you have to treat the underlying cause, because hyponatremia is a sign of a disease. It is not a disease itself, but it's rather a sign of underlying disease. And finally, the most important point to note is you have to avoid rapid correction of the serum sodium, and that's to avoid osmotic demyelination syndrome. And therefore it is recommended never to increase your serum sodium level to more than 9 milliequivalents per liter per 24 hours. Actually, the goal is to increase your serum sodium level to about 4 to 6 milliequivalents per liter per 24 hours. That would be all for hyponatremia. I really hope that you have found this video to be informative and helpful, and please feel free to post any comments or any corrections that you feel are necessary. Thank you again for watching, and hopefully I'll see you with the next video on hypernatremia.